Implants have been around for 80 years almost now, 70 years they've been around, and there's been an evolution in implants. At first, they were very liquid silicone gel within these shells.
Almost like a molasses.
They were very porous, and they would move, and there could be some leakage. With time, the shells got better. Now there's double shells in here that prevent silicone leakage. The cohesiveness of the gel is greater, so you can have cohesive gels or highly cohesive gels. So when you slice through an implant, I think I have a video on my Instagram somewhere about that, but you don't see liquid gel flowing out. They look more like gummy bears.
It's literally like a gummy bear. You squeeze and it goes right back in.
Right. So it's very different. So there's been an evolution over time. With the technology of the shells have also improved with that. So now a lot of the implant companies give much greater warranties. Tell everybody that this is a man-made device, right? It's not meant to last forever. So like anything in your house, at some point it's going to give, right? So it's not meant to be a lifelong device. But that doesn't mean that there's a stamp or a period in time in which that's going to happen.
Right.
So if you think about how long the company is insuring that implant for, I'm going to guarantee you that more than 95% of people are going to be okay within that frame of time in terms of rupture, right? Because they don't want to be paying for you to get these replaced for no reason. So you don't have to change it at 10 years. You don't have to change it at 20 years. If they're doing well, if they're in good position, you're happy with them, they feel good, then you don't have to change it. Now, we do have screening for silicone implants that's indicated by the FDA as well. So that screening now starts after you've had the implants in place for 5 to 6 years, and they should be done every 2 to 3 years. This can be done with an ultrasound or with an MRI. So a lot of plastic surgeons now have the technology to do in-office ultrasound. I offer that myself.
Right.
I was not an earlier adopter like some of the other trailblazing plastic surgeons that I know, but I'm trying to learn from them and gather more data. And I'm screening every implant that comes through my door just so that I can gain the experience to do it. And the software is so amazing, and AI technology is coming into play that you can pretty much scan and you're going to be able to just look at your phone screen or your iPad and know that that implant is ruptured with all the new technology that's coming. So experienced ultrasonographers, because the ultrasound's only as good as the person screening and reading it.
Correct.
Is fantastic. Sometimes when I am not 100% certain, then you correlate that with an MRI. The MRI is probably still the gold standard, but definitely a more expensive technology. Like I don't charge my own patients to ultrasound their implants. I don't know what other people do, but an MRI is always going to get a charge, and sometimes insurance will cover it and sometimes insurance will not.
And like mine didn't cover it. I just paid out of pocket for my breast MRI last year.
Right. And you can actually negotiate good prices with an imaging center to do that. So it's important to know that you have options to do that. So if it's equivocal or we're not sure, we follow it up with an MRI. It's a lot more sensitive to tell you if there's a rupture. And what we're looking for is silent ruptures. So everything feels fine. Everything is in good place, but something's happening, a little crack in the gel internally, which means that you might have a problem in the future that we're trying to prevent. So that's the point in doing these screenings. Now for saline though, I mean, if it ruptures, the water's going to leak out. You're going to know right away. You're going to wake up one morning, you're going to be like, oh, it's gone. You know, so then
the
you know it's time.
Has popped.
The balloon has popped.
Yeah.
So you will know it's time to exchange it. So that's really kind of the difference between the two types. There's advantages and disadvantages to everything in life, right? Nothing is 100% fail-proof or perfect for anybody. And I have patients that request saline implants because they rather not have to have screening. They rather know that if a rupture happens, that they're deflated and they'll have to change it. And I have some patients that are like, oh, I love the feel of silicone. I know it feels more natural to me and that's what I want. And I'm willing to undergo the screenings that are necessary. It's all about getting appropriate informed consent from your surgeon. Yeah. You can never leave the consultation room not having asked all the questions that you want to ask without having an understanding of the process that you're going through.
Now, you were saying, you know, we talked about longevity and having to price out that. Why would be another reason for patients to come in to have revisions done with the implants? So
there are a couple of common reasons. see most commonly within the first year, it's sizing. A lot of it is that they wish they were bigger, and it's because they're adapted to the new normal, right? So they were looking for upsize, 2 or 3 cup sizes. Inevitably, I think 95% of people that come through my office, whether they're wanting an augmentation or a breast reduction, right? They want to be like a full C, whatever that means to them.
Right.
Right? I think we can all kind of picture in our bodies or in other women what we'll perceive a full C to be. But then they get that full C and they're like, well, I mean, now I wish I had gone bigger, right? Because they just got so used to their new normal. So I think as surgeons, what we want to do is really get patients as close as possible to what they're going to be happy with indefinitely. Now, the other reasons that people need revisions is malposition. That scar tissue that forms around the implant is a natural body reaction. Just like if you got shot with a BB gun. Your body's going to want to isolate that BB, putting a capsule around it. It's just a little thin scar tissue. It feels like thin as tissue paper. Now, some people form really, really thin capsules and their pockets stretch over time. Either due to skin quality or weight loss is a very common thing these days. And then the implants shift. So it can shift laterally is the most common thing that I see, because when you're lying down, the implants want to follow the curvature of the chest and migrate laterally. So it's an easy fix to fix that, but it does mean you got to return to the operating room. Superior malposition, meaning the implant stays high, riding high, is another reason. Usually there's a little band of tissue or muscle that wasn't
just
released.
Holding it up on your clavicle.
Yeah. So after you get an augmentation,
it's going to be high anyways.
Your implants are going to be high.
Yes.
Yeah. You're going to look like a linebacker until it kind of settles. It might take a month or 3 months to settle, but after that, they should be in the position that they're going to. So if you have a superior malposition, we have to go in there, release that band of tissue to let it drop. So those, I think, are the most common. Sometimes over time, the implants will migrate below your inframammary fold, which is a inferior malposition, and that means you have to re-tack up that inframammary fold. So that's another reason for revision. And those are really the most common ones. Then long term, if that scar tissue becomes hardened with time, we call that a capsular contracture, which the rates these days are like 5% or less, really, if you have good technique and the newer generation implants.
Especially with the new implants, because they have good data on that.
Very good data. Like I think the Motiva implants have a 1.4% or less, if I remember correctly from their data. The other companies are not far behind that either. Like I follow a protocol that's been very well studied to help prevent capsular contracture. That is my main goal in my operation, is making incisions in the place where it leads to the least amount of complications, placing the implant in the location that leads to the least amount of long-term complications. There are small things like covering the nipples during surgery. We change gloves as we're putting the new implants in, wash out the pocket with antibiotic solution. I mean, I've been in practice for 8 years. I've had no infection. I mean, 0 on a primary augmentation. So that's a really great thing. Bleeding after surgery is very, very uncommon. And one thing I get asked about all the time too is recovery. And I mean, you've seen tons of patients go through
It's different for everybody too.
Stages of recovery.
Some people are like, I just took Tylenol and went on with it. When I had mine done, I just felt like I did a bunch of push-ups. So. Yeah. But I've seen people that are crippled for 2 weeks because they're like, I can't move my arm. So it's different for everybody.